Hi, everyone. We are going to resume with our second panel, or kind of like the third panel for the day. And so please join me in welcoming Dr. Hamid Zaman, the HHMI Professor of Biomedical Engineering and Global Health at Boston University, and the inaugural Director of the Center on Forced Displacement at BU. This second panel will look at anti-Roma racism in public health and medical policies, practice, and research, in which leading scholars and thought leaders will discuss anti-Roma racism as a determinant of poor health, health inequities, and a health stressor in of itself, and examine existing research methods, data, and approaches in view of identifying more robust tools to quantify, catalog, and address the nexus between anti-Roma racism and health. And to try and save some time, instead of a full Q&A at the end, the panel will go straight through, but as their talk is going on, please, if you have any questions and or comments, just grab one of the cards, and FXB folks, myself, and other folks, if you just sort of raise it, we'll keep an eye out. We'll come and grab it and pass it along to Dr. Zaman, and he will incorporate your comments and questions throughout the panel. So please join me in welcoming this panel. Thank you.
Thank you so much, Keisha. Well, there's this thing, or should I just sit over there and just? Okay, thank you. Thank you so much, Keisha. My name is Hamid Zaman. I am a professor of biomedical engineering. I have the tremendous honor of chairing this incredible panel and the somewhat unpleasant task of finishing on time. I have an ulterior motive. I live far. I need to go home and break fast. You don't want me to be hangry. So there's absolutely every reason for that. But more importantly, it's really a phenomenal pleasure. I was just taking notes earlier. I wanted to spend just a couple of minutes talking about some of my own work, and granted, it is focused on stateless communities elsewhere, not necessarily among the Roma, but I wanted to sort of share just a couple of things, if I could. So as we think of dimensions of health access among forcibly displaced in the stateless communities and sort of the element of racism, there are three themes that have emerged in my own work with stateless communities in Pakistan and elsewhere. The first one is the element of trust, and that plays a tremendous role if you have sort of a racist group that is really bent upon denying that trust is intergenerational, or that denial of trust. The second element is social network. Even in the presence of institutions, it's a social network or lack of that social network that plays a tremendous role in accessing healthcare. Again, that social network is really important as we navigate how do you create an anti-racist system where that social network can really benefit from that. And the third one, which is often not thought about, is the environment in which people live. That means physical environment, that means regulatory environment, the presence of informal providers, for example, that means financial environment and things of that nature. And it is often the intersection of these three, along with elements of racism, that play a role in how people navigate that. Also, all of these things have a memory, and I'm happy to talk about that at some point as well. What I wanted to mention was that I am really honored to lead a Center on Forced Displacement at Boston University, which is on this side of the river, just like this institution is. But the idea is to really bring together scholars and practitioners from all over campus, from somebody like engineering directing it, to the associate director coming from gender studies, to humanists and social scientists, ethicists and public health scholars, really thinking about these issues. One of the things that makes me particularly excited about this event is that we want to move away from just focusing on the larger crises in the media. It's not to say that the crisis in Syria or the crisis in the Horn of Africa or the one at the southern US border is not important, but all lives really that are impacted and important. So we are focusing on issues that are important. Magda is on our board, stateless Bengalis in Pakistan and other things as well. And of course, every good deed requires some advertisement. This is our event in about 2.5 weeks. One of the foremost voices of moral leadership when it comes to those who are displaced, Abdurrazak Gurnah, the 2021 Nobel laureate in literature, will be our keynote speaker on Monday, the 24th. If you go to our website, you will see registration link. It's free and open to the public, but we do worry that it might be sold out. So with that advertisement, I'm going to do one other thing. I'm not going to go through the biographies of our panelists and then ask them to introduce themselves as they see fit. So I'll start with our first panelist, who is going to be Petra Gelbart.
Thank you. My name is Petra Gelbart, and I am a gynologist. There is a large body of literature on the clinical encounter as a locus for the genesis or exacerbation of racial and other disparities. Obvious, woman. In the Czech Republic, Roma in segregated neighborhoods die some 18 years earlier than the national average. Compared to the general population, they have roughly twice the prevalence of high-risk conditions such as type 2 diabetes or hypertension, typically at younger ages and with more time between onset and diagnosis or treatment. My interest in attempting to understand select medical research stemmed first from parenting a medically complex child with a congenital syndrome, and most recently in connection with a short-lived project aimed at decreasing COVID morbidity and mortality among mostly Czech and American Roma. I have also been informally and at times formally gathering healthcare-related anecdotes for 18 years through my work with post-institutionalized Romani children and their typically non-Romani families. In the Czech Republic, until recently, all these children came through so-called infant institutes, staffed by doctors and nurses. Many of the clients with whom I work each summer have had multiple encounters with Czech developmental and mental health clinicians. Many of our parents report discriminatory practices directed against their children. It is crucial to note that these children usually present with proper hygiene and quality clothing, in addition to communication patterns and displays of emotion that are more in line with hypothetical Czech norms than with the stereotypical presentation of the Romani patient. An example of the prejudice they may experience is the de facto denial of mental health services based on the idea that the child's problems are caused by Romani genetics or gypsy temperament, rather than by the very real trauma they've survived or by prenatal alcohol exposure. This prejudice is rooted entirely in unscientific beliefs and terrible clinical practice. What's more, most of our clients live with trauma caused primarily by their residence in one or more state-run institutions. The perversions of healthcare goals committed in these buildings and in the discourse of their apologists are sometimes heart-stopping, despite the efforts of many well-meaning employees. Our young clients thus start out very much disadvantaged by the healthcare system and continues to face a range of intersectional barriers, including ableism. I will readily admit to my own negative bias in evaluating Czech and Slovak medical as well as mental health care. This stems in part from my own limited encounters as a patient and the mother of patients, not to mention the granddaughter or cousin of Romani patients in particular. And here's my button, ask me about my horror stories. By the same token, however, I reject any simplistic views of why Roma tend to have relatively poor health outcomes. For the purposes of this paper, I consulted a number of academic and non-academic publications in Czech and Slovak and interviewed 2 former Romani coordinators of a large-scale project run by the Czech National Institute of Public Health. I spoke with 2 experienced Romani nurses and used published or orally reported testimonies of other Romani healthcare workers. I also asked some of my relatives in-depth questions about their views of Czech and Slovak healthcare. I wanted to see to what extent these data sets, theoretical frameworks, and anecdotal reports would change my own subjective impressions of interethnic healthcare issues. My dearest cousin, a half Romani, half Sinti woman of 50, has had to navigate the regular as well as forensic healthcare system on behalf of her adult child with schizophrenia, with mixed results. Given the frequent comorbidity of mental and somatic issues, it is not surprising that her son's physical health is very poor. Despite these life-altering challenges, and despite her daughter's recent experience of apparent discrimination as the parent of a hospitalized child, my cousin Jana has an overall positive view of the Czech universal healthcare system. Like the nurses I interviewed, she believes that Roma are given the same medical treatments as non-Roma. At the same time, Jana is aware of the de facto reduced access to care faced by many of our relatives in a Slovak Romani settlement, especially by those who lack the level of social integration needed to engage in normative communication with members of the majority ethnicity. Indeed, NGOs and Romani healthcare mediators will point out humiliating practices in both countries, such as hospitals segregating birthing mothers. Still, a number of Roma, even in the poorest areas, are satisfied with much of the healthcare they receive. It seems that for every anecdote about healthcare workers suspected of racism, there is a neutral or positive story. It would also be helpful to contextualize unacceptable behavior toward Roma with the harsh treatment of white Czech patients. Admittedly, this angle may not be one I would consider if I weren't generally white presenting and if I did not have white Czech friends. And even the complaints of my non-Romani friends may not always be objective, just as with my fellow Roma. As an evidence-based developmental and mental health practitioner, I find the unscientific or impatient demands of some people I love to be hair-raising, and thus would not blame their clinicians for refusing to entertain them. Now, how attentively do Roma receive evidence-based information? This question cannot be considered without noting the dietary habits, alcohol intake, or willingness to follow medical directions among their majority neighbors. Yes, Roma rates of cigarette use are far higher than the national average. They refuse to wear masks to filter airborne particles, and many decline to be vaccinated against COVID. But this should not be surprising in a country where nurses can be seen smoking outside hospitals. The nation as a whole cast off masks many months ago, and anti-vax or anti-mask rhetoric runs rampant, not just in the general population, but among many physicians as well. Romani NGOs, including my own, have spectacularly failed at protecting Roma, including my now dead grandfather, against COVID. So have Czech media. Unfortunately, many studies attempt to provide data on Roma as if we lived in a vacuum. Opinions of clearly prejudiced healthcare workers and experts are taken as fact, whereas Roma themselves are very rarely consulted on the matter. Formally educated Roma, too, are often effectively excluded from or silenced within reports and healthcare access projects. On a different side of the spectrum, numerous reports by pro-Romani NGOs and sympathetic academics paint poor health as somehow imposed on Roma from the outside. Ethnographic research, such as a 2021 thesis by Jana Bajtkova or my own interviews with Roma, suggests that both sides are wrong. Czech and Slovak Romani families do, in fact, have cultural specificities, such as fear-based communication patterns that are read as aggressive, which in many, though certainly not all cases, affect what each party takes away from the clinical encounter. And by virtue of poverty levels, as well as racial trauma, they have all the risk factors one would expect. In my experience, truly listening to Romani professionals can provide the nuance most discourse seems to lack. When a Romani nurse tells us that the behavior of many, if not most, hospitalized Roma and their families greatly exacerbates existing prejudices among staff, while also significantly reducing the chances of treatment success, we should listen. When Romani psychologist Andrea Tybenska writes that failure to account for supernatural beliefs among Roma can skew the diagnostic process, we must take note. When Romani project coordinators say our people tend to lack awareness of how what they ingest affects their health or how certain substances irreparably harm the fetus, we should prioritize access to relevant information through channels that are trusted by Roma across all social strata. But perhaps we could also consider what would happen if we formulated the information Roma receive about their healthcare options the same way many white Czechs become supposedly informed about Romani culture. One recent nursing textbook could serve as a template, with its claims that Roma are ruled by hot-tempered emotions, maintain various exotic practices that real-life Czech and Slovak Roma may not even know about, truly fanciful stuff, and so on. Thus, in a gajological brochure for Roma on how to approach white healthcare workers, we could use similar language, which I am quoting verbatim from the textbook with just a few words added. There is no tendency toward introspection, self-knowledge, or self-evaluation among ethnically Czech doctors and nurses. They do not spend time thinking about their experiences. They lack motivation toward personality changes, and their low intercultural educational level is manifested through naivety and lack of critical thinking, greatly reducing their ability to function in a multi-ethnic society. Practicality and orientation toward the present are key. The heavy effect of in-the-moment emotions stemming from prejudice is typical in their thought processes. They are easily swayed, and they have the ability to become excited by illusions, such as believing that all Roma see health as a low priority, or that scientific consensus is overrated. In conclusion, unexamined ethnotheories, myth-making, and unscientific beliefs among both Roma and non-Roma contribute to subpar interethnic communication and poor health outcomes.
Thank you so much, Petra, for a fascinating paper and staying on time. If colleagues, they have questions, if you could write, and as somebody said, I would not name that person, write legibly. Then I'll be happy to sort of collect them and sort of look at common themes and then pose those questions to the panelists. Thank you so much, Petra. Moving on to our next colleague, Carmen Gheorghe, will speak.
Yes, thank you. So my name is Carmen Gheorghe. I'm a Roma feminist activist and a scholar. And 7 years ago, I started in Romani Association, which is a Roma feminist NGO I'm leading in Romania. I started to research the topic of sexual rights and reproductive healthcare to better understand the issue. When I was puzzled about the topic since 2013, when a far-right group in Romania launched a campaign. They were giving 40 euro to each Roma woman who would agree on sterilization. Of course, authorities intervened very fast. They took them into custody. The case was actually quite fast solved. But there were also other politicians, which earlier Ioannida was reminding that they were going public on their ideas on pro-sterilization opinions. Now, of course, during all this time, we had a lot of discussions within our group with the Roma women that we work, and there was a question which arose every time, and this is practically the main question that I will start my presentation. Do Roma women in Romania have power over their own bodies? And I heard within the previous panel that there were already discussions about this, and I hope there will be also in future. But when I refer to power, I refer to an ecosystem where autonomy, which is based on an informed decision free of coercion, right? Doctors' confidentiality and privacy, without, for example, virginity tests, which were until very recently happening in Romania, non-discrimination in treatment, equality of access to services, including affordable services, yes, and accountability of the medical staff, which is still not going, it's still not happening in the country as well as in many other countries when it comes to Roma women. So I've been doing research some years ago on Roma motherhood and access to healthcare. And then in 2020, I conducted a comparative study research for Romania, Italy, and Finland with a feminist intersectional methodology. It was on several topics, but including access to healthcare. And I really recommend you to see this study, report, which is on our website, because it has a lot of narrative and stories from women in different countries during migration in different political contexts, and it's a huge amount of work that we've put to have this qualitative research. I want to share with you some of the research conclusions, and of course, some are not new. They were already mentioned by other panelists. One conclusion, which is kind of sad, is that most of the time Roma women tend to minimize the health issues that they have. Even if it puts them in serious situation, most of the time Roma women would not go to hospital, especially if there are tests which need to depict situation of their reproduction function, for example, right? Rather, they access the system when it comes to children and family, which are always a priority. And most often situations where they have to go to the doctor is when they have to give birth. A study made by Save the Children in 2021 showed again and again that many Roma women go to the doctor when they have to give birth, so not during the pregnancy to monitor it, just to give birth. And they use the national emergency number because most of the time they do not have a doctor to monitor them during the pregnancy. That's why in many situations, as you heard before, the mortality rate during pregnancy or when giving birth is at least 3 times more comparing with the national average. Of course, it is not news for all of us that the main reasons for some of the conclusions that I mentioned are based on the races intersected with low socioeconomic backgrounds, transphobic and humiliating treatment treatment they get from all categories and professionals, from receptionists to nurse and doctors. And this is something that we found out during research. And also while collecting information in our work at the grassroots level. And most of the cases that we encountered were happening in the public healthcare services, right? Now, when I talk about social class or socioeconomic backgrounds, I'm referring mainly to low level of education, low income, jobs where you have more insecurities, and housing situation and residence coupled with color. And I will come back to this housing situation. I want to share with you some of the quote because the research was put in the center Roma women's voices and experiences, not just in terms of subject of research, but also women with their own voices. So it has a lot of quotes and stories, and I would like to share some of them with you. I was in pain and they were shouting out loud that we are dirty. I felt offended then. Why do they say that we are dirty? How could anyone go to the doctor dirty? Because that's how you gypsies are. You spread your legs. A racist woman told to me. But I would notice the difference. Romanian women were treated nicely. They didn't argue with them. They didn't yell at them. Another important conclusion, and this is to come back to the housing situation, of course, when it comes to health and reproductive rights, is even more problematic for women who live in segregated communities. Housing deprivation coupled with location of the community, settlement or camp, usually is in a segregated, isolated, marginalized area, determined in many cases higher mortality, maternal mortality, teen pregnancies, and forced marriages. And for example, and I already mentioned before that Roma women's mortality rate is 3 times higher comparing with the national average. Now, theoretically, health services are available to all, but there are costs associated to any diagnosis and treatment. There are waiting time lists, which increase even more during pandemia. The distance to public hospital is at least 40 kilometers, as in 12 years ago, the Romanian government shut down 67 maternity hospitals. There are still great payments that you have to give to nurses and doctors. Abortion is often discouraged in the public sector. In Romania, around 19 hospitals in the country still perform abortion and have a doctor, while the private sector, an abortion costs about 500 euro. There are, of course, superficial checkups and improper medication during laboring or afterwards, as well as medication related to family planning. Another conclusion is the access of transgender Roma women to health services. And the report has an important component about lesbian and transgender women access to healthcare, as of course, the interaction with public sector is quite racist. The negative image of Roma women identity is overrepresented and overwhelming during the research. And this probably you will see if you would be interested to see the research. And I'm quoting here again. There is this fear that you are at their mercy. And especially when you are visibly a Roma and you have no education, it is horror. I think it is a fear that we can never understand if we don't experience it. To be at the mercy of someone who could harm you only because you are Roma. I think it is horror, and honestly, I've noticed that many women have this fear. Some of the most shocking experiences happen, unfortunately, when women give birth. For example, when they heard that I'm 40 years old and I have 6 children at home, and the girl is the 7th child, they behaved so badly. They cut me in such a way that I couldn't stand on my feet. I couldn't sit on my back or in any way. When I went back to the hospital to get my stitches removed, the nurse told me, "Were you a pig on a table or a human being?" To them, I was. That's how badly they treated me. Roma women, as I was saying, are sharing a lot of stories within the research about how they are labeled, judged, or excluded. And I quote again, "I had a negative experience with a gynecologist who talks vulgarly. She talked vulgarly not only to me, but to other women too. And every time you could hear her saying, 'All you gypsy women know is to spread your legs and have babies. And then you come to me moaning.'" So, when accessing the reproductive healthcare services, the conclusion is that the poorer you are with lower educational level, without a job, not white passing woman, and being seen different as transgender woman, for example, the higher the risk to receive a different treatment or to be traumatized by the experience of birth or the contact with the public service. These institutional practices are in fact influenced by the structural inequalities embedded in the design of some health system, especially the Romanian case. And I heard before from my colleague, Czech Republic is also a champion in this, Slovakia is also a champion in this. So unfortunately, all the research that I did, which was subsequently put into practice by developing different projects that we ran in Romania oftenly, made me to conclude that Roma women and adolescents' body are instrumented, objectified, and sexualized, associated with hyperfertility, or are blamed for teen pregnancies, as it happened because of our national statistics. Their bodies, or I could say our bodies, become the issuer of negative social and cultural message and institutional practice. The bodies, with other words, become a product of the social cultural construct of hegemonic heteronormative practice, where women and adolescents unfortunately have no power. There are many things that could be said, but I think I overpassed my limits, so thank you for attention.
Thank you so much, Carmen. Moving on to Veronika.
Thank you so much for having me. It's a really very important experience for me to be here. The talk is authored by Mihai Surdu and myself. Mihai is here on that photo, and there's also Gudrun Rappold, a geneticist who's working with us. And I will present some results of our study on genetic studies of Roma. We have 2 publications in 2021. One was in Nature, and the other one was in Science in Context, which is a history of science journal. I know that the Nature comment drew a lot of interest because we spoke a lot about ethical issues, but my topic today is a bit more on representing vulnerable populations. It's more an epistemic issue, and I think it's super basic for understanding how people from the medical fields and geneticists view the Roma, because what I will present is what they think Roma are. So they think this is sound academic knowledge, and that's important to keep in mind. We have analyzed 450 genetic studies published within 100 years. Most of them have been published since 1990s, which surprised us. And the number that pours out of this research trend is just growing. Most of them are medical genetic papers, but there are also forensic genetic papers that are very interesting in their own right, and then population genetic papers. Our argument is very basically a sampling criterion has been turned into an essentialistic description of Roma. And you can also put it the other way around. The sampling criterion was taken from an essentialist understanding of Roma. Researchers claim that European Roma are a genetic isolate, that they are subdivided into several isolated subfounder populations, and that their genetic isolation rests on tradition, endogamy, inbreeding, consanguinity. Yet they only accepted people to the sample, to the genetic sample, who were somehow identified as Roma, who lived in societal isolation, who practiced endogamy, and or who suffered from genetic disease. So the focus was extremely narrow. Further, after the analysis in the lab, individual DNA data sets were removed from the sample if they signaled too much European admixture. The results then became generalized for all Roma in Europe. And this is one quote from one of the papers: all European Roma appear to descend from a low number of founders and to have diverged into socially distinct endogamous groups after their arrival in Europe. And sentences like this you find in just every of these 450 papers. There's a biohistorical narrative about Roma history in these studies. And of course, the researchers want to solve a lot of puzzles in this research field. So the first most important biohistorical narrative is Roma come from India. And then researchers want to find out where exactly from. And the second part is Roma are dispersed all over Europe. And then they are interested in finding out the migration route and when was that? Was there one founder population or many, and how are they related? Then they claim that Roma are isolated by traditions of endogamy and consanguinity, and as a group at large, but also these single sub-isolates are also seen as isolated by endogamy. And then the question for them is, do they represent the proto-Roma population from India, or have they been admixed ever since? And then they say Roma are genetically distinct from Europeans. Sometimes they call them white, sometimes Europeans. And they say this has happened by bottleneck events, founder effects, mutations, and drift, just genetic terms. And then for them, it is important to ask, what are the results of the comparison with Europeans useful for? There are quite many Roma collections in the medical field. These are biobanks or databases that have ethnic annotations. Some of them were collected decades ago in the 1980s already, or 1990s, and they are used until today in vast numbers, thousands of samples. I have two quotes from a geneticist CV and a conference abstract from 2012. It's still online. So he said, well, they have done their work based on analyzing biobanks of Roma population samples. And he says, the Roma collection provides an exceptional position for pharmacogenomic research in his department. And this is a very soft language of usefulness. There are quotes like, the Roma are a unique resource for research. They are very instrumental, very important, of high value for our research, for the health of the global population. There is a historical background to that. The collection of data started in the 1920s, but not DNA, of course. Since the 1980s, biosamples are being kept in freezers. It continued until the early 2000s, and there were also large-scale sampling projects targeting Roma in Central European countries in the 1970s and after 1990. I will show you one. And it's important to note that there were no informed consent procedures in these countries until the early and mid-1990s. So all these samples, or most of the samples that people work with, have no informed consent. Particularly the biomedical genetic studies are interesting in their context. So researchers often frame them as studies of large families, of isolated communities, of rare diseases, or of Roma biobanks. They praise them, as I said, for the usefulness for pharmacogenomics. We have made a list of 16 monogenetic diseases and more than 78 complex diseases that have been investigated predominantly with Roma samples. The mutations of the monogenetic diseases are being understood to have originated within the isolate. So they are called Roma private mutations. And the sampling has taken place in clinics and in doctors' offices, but also in door-to-door collection approaches. The current research interest, which interests researchers at the moment, is to look for corresponding effects between multiple mutations in one single individual. There are long-standing cooperations between Western and Eastern European teams dating back to the 1980s. And just one sentence on this here, the results are often framed in very stigmatizing words. This is our list of the 16 monogenetic diseases. Well, the complex diseases reach from depression, schizophrenia, just everything, mental conditions, but also physical conditions, asthma, whatever. And hardly any of these studies reports on benefit sharing or the intentions of benefit sharing. Here's one example, an epidemiological study of neuromuscular diseases in what they call gypsies in Bulgaria. And the neuromuscular field is the one field where Roma data is extremely valuable. So for these diseases, Roma data and samples have been exploited most. They tell us here about how they have sampled. A neurological screening of hereditary neuromuscular disorders using the method door-to-door was performed in 2,500 towns and villages, having predominantly Roma population in the country. Those towns and villages where pedigrees with hereditary neuromuscular disorders resided were visited from 2 to 10 times with the aim of collecting pedigree information, etc. The fieldwork studies covered a period of 20 years, 1994 to 2014. 97% of the Roma population living in compact gypsy quarters was encompassed, which is vast. We call that a genetic census, actually, because it's just the whole population of these villages. And they say the field studies were performed with the support of the local Roma foundations and Roma health mediators from different parts of the country. And that might be true, but I don't think that these organizations knew what they were contributing to. The most valuable, really most valuable database and resource for research in this field for decades. That's what it is. Here is a recent review, Population Genetics of the European Roma. It's, we have to respond to that. They repeat all these narratives that I have shown you. They try to balance that with accounts of discrimination, etc. And in the section about the biomedical implications of the complex Romani population demography, they say, on average, 1 out of 8 Romani people is a carrier of one of the 5 more common Mendelian mutations. All the risk factors were reported to be present more regularly in the Romani population compared with the majority population, including smoking, sedentary lifestyles, unhealthy dietary habits, low socioeconomic status, and alcohol consumption. And when you look at the number 1 out of 8, you must be aware of the fact that the sampling has focused on families where these diseases are very frequent, right? It's not in any way representative. Yeah, thank you for your attention. If I had more time, I would show an example of how this cleaning of databases happens and how that leads to bias, but I think I'm over time. Thank you.
Okay. I wanted to also start by saying what a privilege it is to be here and to be speaking with such inspirational scholars and activists as well. So I'm Lois Orton. I'm a researcher from the University of Sheffield in the UK. And for my talk, I'm going to talk broadly speaking about the way that the health of Roma populations in Europe have been understood, both in policy and also in research, some of the problems with those understandings, and also how we can start to try and destabilize them a bit as well. So a lot of this will be talking from my own research experience, but then also kind of reflecting with others that I've kind of engaged with in these discussions and sort of putting forward some of the ideas that we have, how we might do things a little bit differently. So perhaps a slightly different focus to some of the other presentations, quite reflective as well on kind of what I've been doing and what others have been doing in this field. So I just wanted to start by saying a little bit about the kind of current situation in Europe and the way that the health of Roma populations is understood. So as we've heard already, obviously there's been a lot of discussion around sort of the genetic elements of Roma health and wellbeing, and also understandings around the health of Roma very much being kind of framed as one of sort of contagion as well, and what might be termed social Darwinism. So sort of the health of Roma being posed perhaps not as a problem for Roma themselves, but more as a threat to the wider population. And we've heard already today lots of examples of how this has played out recently around the COVID pandemic and around the kind of concerning of movement of Roma populations in response to that. So obviously this imaginary of Roma as being dirty and diseased has not gone away, it's still here. But we also have seen a lot of other kind of developments recently, particularly in a kind of policy arena around Roma. I think this is something that maybe Martin will talk a little bit about later as well. But, you know, if we think about the decade of Roma inclusion, we saw how issues around sort of Roma inclusion and integration became high on the political agenda. And that was followed by a number of EU strategies. So the EU framework for national Roma integration strategies, which forced all countries in the EU to have their own kind of Roma integration strategy. And this was in 2011 initially, and it's recently sort of been renewed, very much kind of framing the situation of Roma as one of their kind of not being integrated in what was considered to be kind of just and civilized societies within those countries. And if only Roma were able to benefit from mainstream housing, education, employment and healthcare, then, you know, the situation could be rectified. More recently, I think since the programme, these frameworks have been renewed, there has been more of a focus on what they call discrimination and anti-Gypsyism. However, the role of structural racism and institutional factors, you know, very much kind of originating within those, you know, EU structures themselves as well, are still not recognised in those initiatives. So very much kind of focusing on sort of communities themselves. And the EU Roma Health Report was published in 2014, so quite a while ago now, but you know, it's kind of like the biggest attempt at bringing data together. Obviously, the data is very limited, so there's a lot of issues with the data itself. And yeah, there's a lot of problems with this report in terms of the heterogeneity of the different populations that were included. So 11 countries with different Roma populations living in very different circumstances. But the conclusions were that across these different countries and different experiences, that Roma experience worse health than majority populations. And again, these majority populations were defined in different ways as well in the different kind of settings where these studies were conducted. But, you know, these findings were put forward, and it's very much kind of framed the way that the health of Roma is understood, even to this day. So, yeah, looking at explanations for why there were these differences between Roma and non-Roma, the report itself acknowledges. It focuses very much on lifestyles and health risks. So again, very much locating the problem within Roma communities themselves, and not looking at any kind of wider structural processes that might be creating the circumstances where this is occurring. So unfortunately, most research that has kind of followed since these reports were published has kind of tended to just reinforce those understandings, and particularly sort of research coming from kind of policy and practice perspective tended to just work with the norms and kind of perspectives that are put forward in these reports rather than necessarily challenging them. So quite often research will draw on sort of secondary data sets and will analyse kind of pre-existing data, which obviously have its own inherent problems, and tends to not be particularly critical or to look for the intersection of multiple different dimensions of inequality and how they might interact with each other and create specific circumstances for Roma communities. So there's very little kind of very little research that actually takes a kind of multi-dimensional approach, looking at the interactions of these different processes, and particularly there's not much sort of theory that's used, such as intersectionality, to put forward better understandings of what's really going on here. So this creates an environment where we have these kind of really overgeneralized, homogenized accounts of poor Roma health that don't take account of wealth of differences across many diverse populations in different settings. And this is coupled then with the overemphasis on individual and community level factors. So these very much blame-focused lifestyle and kind of health risk explanations, which creates this environment where there's this kind of singular they mentality. They have a problem, they, the Roma out there, nothing to do with us kind of thing. So they're blamed for their own poor health, and it really reinforces those cultural stereotypes and pathologizes Roma as a problem, while overlooking the kind of intricate social, political and institutional factors that obviously create those circumstances. So obviously this is an example of cultural essentialism, which is not unique to Roma, which obviously is something that is experienced by many racialized groups, all racialized groups, but it really does act to cement inferiority and to absolve the powerful from their responsibility in this as well. So I think we all here will agree that that's not an adequate explanation of what's going on, and that Roma are not inherently different or deficient compared to other populations, and that there is a very strong case for interpreting the disadvantage as a result of a coalescence of different forms of discrimination and oppression and poverty, and also in some cases migration as well. So we need to be very careful in, unpicking these kind of underlying processes and looking at, these forms of injustice, not just today, but the legacy of past injustice as well, and how that has been transmitted across generations as well. So I just wanted, if I've got time, I don't know how much time I've got left, but to talk about some of the things that myself and other colleagues, okay, I'll do it quickly, have been considering for, ways forward to do things a bit differently. I'll try not to speed up too much now. So one thing that I think is really important is for us to just be vigilant in how we are kind of reinforcing this ideology of inferiority. And that's both in terms of the kind of questions that we're asking in the research that we do and the methods that we're using as well. And to try and sort of create spaces where those who are kind of being oppressed can actually challenge us in those methods and those questions as well, and get us to see things a bit differently. And myself and actually Martin and Angela Kose, who isn't here today, but we've been sort of using collaborative autoethnography as a way of doing this and a way of structuring those reflections and challenging each other on how we could do things differently. Some more specific things that sort of I've been thinking about with others is about how we need to be really specific about the populations that we're talking about when we talk about Roma, because obviously there's great diversity and we don't want to be reinforcing that singular they mentality. And connected to that is in terms of challenging essentialization, is it learning from other groups who experience similar things too. So these processes are not just impacting on Roma, they're impacting on other groups as well. So learning across different experiences could help destabilize the focus from the individual back to the kind of more structural level. I think it's also important to learn from other ways of knowing. So other kind of non-Western, non-white methodologies and epistemologies might be useful. So we've talked about intersectionality, which I don't think has been fully explored with Roma, but there could be other sort of conceptual frameworks that might be useful. Particularly, I see some discussions around the intersections of critical Indigenous studies and critical race theory. Sorry, I'm going too fast, aren't I? But I think there's a lot more that could be done there to think about these different ways of exploring these things. I think it's also important, as we've heard, to take a long-term view and to see how these processes roll out over time and also across generations. And I think this is mainly my final point, is about turning the lens back on policy as well. And I think we've heard a lot of that today anyway, but how it's important not just to focus on Roma, but to actually unpick how those involved in policy processes and the documents and the everything else that's produced do reinforce this kind of this oppression and trying to destabilize the understandings that are very much taken for granted and thought of as the only way of knowing this problem. So it's useful to actually involve those involved in policy in rethinking, trying to get them to rethink the way that they understand these problems and to understand that that does have a critical outcome in terms of how it's acted upon as well. I could say more about our institutions and how we kind of need to sort of challenge these things, how we need to work together in solidarity to try and challenge the structures that prevent us from doing this kind of research, but I think probably haven't got time to get into that now.
Thank you so much. So if other colleagues also have questions, then I'll sort of try to get teams together and then ask them towards the end. Moving on to last speaker before our discussion is Mark.
Yes. So thank you for the invitation and for the whole team and for launching this event and this very important Roma program with which we are very proud to collaborate. I'm coming from Central European University, which has a small Romani studies program. Our chair cannot be here, Angela Kocsi, but I'm very happy to represent the organization. And I will also talk a bit about data. So at the end of the previous panel, there was a lot of talk about data. So I will show you some recent data coming from the Fundamental Rights Agency of the European Union, where I also work, but I don't represent the organization now. And I will talk a little bit about also these Roma integration strategies. just as an advertisement that we are a small program, but enthusiastic. We do many things, including a preparatory program for Roma students. And I will jump on that. We are very proud to have this journal in which some of you published, and we would like to invite you to submit paper for us and think about ways of collaboration. It's an open access journal. We have some health related papers, for example, on Roma mediators as a new tool of neocolonial rule over Roma. So I encourage you to read a bit our papers, but let's move on to the data. So these are, to my knowledge, the most recent data we have on Roma, and they are coming from 2021. They are comparative data, and it was done in 10 countries. These are just the sample sizes that you have an idea. And the first, I just selected some of the slides, so it's all available online, and I'm happy to share with you. But these are experiences of discrimination in any field of life that is significant, and it can be healthcare, it can be access to a restaurant or education. And you can see that in some country, EL is Greece, for example, or Portugal. It's more than half of Roma population reported such discrimination for the research. And the EU average is 25%. So every fourth person who identified as Roma experienced discrimination. But on the other hand, it's very interesting to see how many of these people not reported discrimination, and it's more than 90%. So I think it could be the subject of another presentation, why basically no Roma who experienced discrimination reported to any bodies or any authorities. But the numbers are, you can see, is basically over 90% in all the countries. Concerning life expectancy, we were talking about it, but the EU average is 10 years. So Roma live 10 years shorter than the non-Roma population, and you have specific data from other countries as well. Let's move on to some slides concerning healthcare. So these were experiences of discrimination in healthcare. It's around 20, 15, 30% who reported some kind of discrimination. Another important issue is having medical insurance. And you know that the European system is a bit different as the social security system we have there in European countries. But I was still astonished if you look at Romania or Bulgaria, that less than half of the Roma have healthcare, which is kind of unimaginable, I think, in a European country. But these are the data that we have. Moving on to the Roma strategies. So we are all talking about data-based policy making, and I'm coming from a European context, but I think it's also relevant here in the US, that all EU countries prepare these so-called national Roma integration strategies, which are also partly inspired by actually policies developed in the World Bank and the UNDP, and also there were a lot of American policymakers involved in this. But to cut a very long story short, Eastern European countries have been implementing those strategies for more than 3 decades. It's interesting that Western European countries started to do it only since 2010, as Lois mentioned, but they also have a significant Roma population in France, Germany, the UK. But basically these are, I would say, small-scale targeted policies. And in the field of healthcare, for example, you can train health mediators or Romani nurses. But I think one lesson that I would like to draw attention, and I think it's in line with the other presentations, that they are just not able to tackle deep-rooted racist prejudice. And also to link back to the first presentation about social support and empathy. I think we don't have measures for that, but if you are familiar with the European context, this is really lacking. So we don't have any support for these policies. And also that there is in a way, a justifiable mistrust of public bodies. And I think they are also very well founded. So I think beyond the statistics, it's very important to see the stories that Petra and Carmen mentioned about the racist nurses books, and also these horrors in the maternity wards. So I think there is a very good reason for mistrust. And basically, just as a final slide, that how we could go beyond social inclusion and to talk about social rights and welfare rights and access to all these services. And for that, I think you need a much broader strategy to tackle racial injustice. And I think that's why such events are very important for us in Europe, that at least there are some efforts in the United States, but also we heard that the backlash about these efforts, but I think it's still very important for us. So thank you for your attention. I'm looking forward to answering some questions.
Thank you so much, Martin. I've gotten at least one question, and it's relevant to some of the conversation. I'll move on to our discussant, Nancy, and then we'll sort of try to combine some of the questions. So please keep them coming. Thank you.
So first, thank you very much for having me here at this panel. I personally have not done research on Roma, but I have done a lot of work on racial discrimination in the context of the US with an eye towards what it means globally and working in some other country contexts as well. Secondly, I want to just say, as somebody who's here in Massachusetts, I'm very clearly, I pay heed to critical Indigenous thinking, and I am on Indigenous land. So that's a beginning part for all presentations. I want to offer two different sets of comments. One, some general reflections on what I've heard, and then some very specific on this extremely rich and important panel. And I will start by saying it is both infuriating and tedious to hear the replication of scientific racism again and again and again, across time periods, across countries, directed at different people who absent themselves from the responsibility for the racism that they harbor and which they try to dress up in scientific terms. Because the stories that we're hearing here today can be replicated in the United States in any number of populations. They can be replicated in any number of countries. So I think it says something pretty profound about the science and both the social production of knowledge and particularly the production of scientific racism and the harms that it engenders, and it become embodied. So that's a framing for me that this is not unique, but also historical specificity matters. To understand the health of any particular group, whoever they may be, you need to know the actual histories, not the glossed over histories, but the histories that are actually the lived experience and that become embodied. And that's what these data also show. So that's one part of general framing. And I think that it's also really important in all of this to always be aware of the two-edged sword of data. The two edges are, the first is quote unquote, no data, no problem, as in if you don't have data, you don't understand what the problem is. And those data can often be suppressed or not captured in ways that are meaningful. And the second part of the problem is bad data, big problem. That's the other edge of the sword. So that if you do not have good data, you can actually further cause harm. And a key thing is with any of these kinds of data for the social groups involved is to understand who and what is setting the boundaries. And I mean boundaries in multiple ways, literally physical boundaries of nation states that have control over populations and their data sets. How porous are those boundaries? Who set those boundaries? Boundaries of the categories themselves. Who makes those boundaries? What becomes the census data or the categories that are used in health systems? Who counts as genuinely being of a certain category versus not? Who has input into making those decisions and into interpreting the data? And the other thing that goes with that is that you can never use as any racialized group, any group that has been the target of any kind of discriminatory frameworks. You never can look at data on that group by themselves without putting it in context. You should never have data that is just that group without any economic data, that group without any data. Intersectionality gives some of the framing for this, but it has to be at multiple levels. So there are frameworks. What I've done with ecosocial theory of disease distribution and others is to have a consistent framework to ask about the multiple levels that are involved across the life course of what the exposures are and by historical generation. People who were born in 1900 have different sets of experiences than people who were born in 1950 than were born in 2000. I actually have a student who was born in 2000, which is a little shocking how that happened. But be that as it may, it's really important. You can't just say 40-year-old. You have to know 40-year-old where and in what context and when. So these are some framing principles. But another key one that I want to bring before I get to my specific comments is that you're always triangulating across sources of information to understand. There are the stories people can tell with their own voices, but that depends on what they're able to say and what they're willing to say. That's really different than the stories that bodies may say, whether or not people are able to articulate those stories. You have to bring these together, as well as bring together bodies of larger data that look at who is benefiting and driving what the inequities are. Because to the extent that the research always focuses on who's harmed and not who's doing the harming and benefiting from it, you just end up with on the same merry-go-round again and again and again. So part of the thrust that's happening that you hear from these different panelists of beginning to move to exposing the systems is asking who benefits and why. How is that driving what is going on? And also the other thing to say that's a consistent theme is this idea that there is an essentialism, that people are defined by their biological inheritance that translates into their behaviors, not the social inheritance and who shaped that. So if you do not consider these things together, you do not have a full accounting for population health. And the other thing that I would say in hearing this, and again, I'll go to some very specific comments, is that it is striking that the arguments that are being discussed now with the latest data on clinical biomarkers or genetic markers or whatever could be replicated except for the technical advances in the biophysical science with the discussions that were happening in 1800 about dividing up Europe, for example, into its different national groups. They just didn't have the data that they would dream only to have the kinds of data that are available now. So it's really important to think about that and think about the roles of the systems of who is benefiting. And I would need to learn and have instruction from people that are enmeshed in Roma work to figure out who you think are the ones that are benefiting from the status quo, because that's a key question. And I've looked at that a lot in the US context about racialized inequities in health, but I would need to learn from others who are engaged to find out who you think are the ones that are, again, perpetrating this and why. Some specific comments. First, the framework that you were discussing about political interactions. Two things to say on that. One, I learned from colleagues, I've spent a bunch of time in New Zealand, the Māori framework of cultural safety, which is very different from cultural competence, which is always us learning about them. Cultural safety starts with saying, who are you in your context? What are your responsibilities to know about your society before you take care of any patients in that society? And it was developed by Irhapati Ramsden, who was a Māori nurse, and is being increasingly taken up in Canada, a little bit US, but where there are indigenous populations. And I think it's a really helpful framework that sounds very applicable here. Second thing is, of the types of discrimination that people self-report, it is almost always by self-report, the least in medical care settings. And when you think about it, there's a good reason for that. That's not where you want to be discriminated against. That's really scary. That's like not good. And it's a consistent finding for a lot of populations that that's where you'll see the lowest self-report. Then you start bringing in implicit association tests, observer participatory research, documenting the kinds of stories you tell, and you get a different picture. So then you have to ask, why would people be scared and not want to say even to themselves? But if you ask them about whether other people are discriminated against that are part of the group at issue, you'll see higher rates of reporting. So what this then leads to, which is I think another part, is that in bringing these issues together is about how does fundamentally putting equity at the heart of the research improve the rigor of the science, improve the quality of the data, and improve the quality of the science? This is not just an add-on because it's like nice to be equitable. It's actually imperative. Next comments that I want to offer also is that, again, with the stories bodies tell, what you were describing around genetic isolates, I mean, that's been done in the US and many other countries as well. And again, the decontextualization of data and acting as if the data just exists and the people don't live in a society that has actually caused spatial social isolation is really problematic. And there are ways to address that by looking at what the policies are, saying this is a group that lives here, but guess what? Why do they live here? What shaped that? How did that happen? That's part of the story as well of what the exposures are, let alone, I won't even go into the genetic reductionism, like that would be another whole like rant. And the other thing to say that I would just say in response to what I was hearing is, again, that it is really critical, these ideas of understanding what you're bringing up around heterogeneities and across the different country contexts, to again historicize that, to ask how did that get there, so you know what the right kinds of variables are to look at, so that you can get at the structural variables that contextualize those data to begin to understand what needs to get changed by whom to make a difference. So there are ways that I would say that of making alliances with other groups that have also experienced genocide, that have also experienced settler colonialism, that have also experienced fundamental racialized discrimination that is tied into exploitation, whether it's for their labor or to take their property. That those are fundamentals to understanding what's behind the kinds of data here. And it's about white supremacy in part, but it's not only white supremacy, because this kind of work, as shown by eugenics, has been replicated in many other societies that are not just only on a white axis. It's fundamentally on a biological determinist, essentialist eugenics axis that needs to be challenged. And other populations have also been considered intrinsically dirty. But dirt, remember, is famously in anthropology, that which is out of place. Well, out of place for whom? And who really needs to be present?
Thank you so much. So I'm going to take a few questions and combine them. This has come up, and I'll ask Veronika to start. And again, in the interest of time, and we will, I'll try to ask specific colleagues. How do the Romani people feel about being researched?
Can't say how the Romani people think about this. The people I know were simply very shocked because they didn't know, they had no clue. I have never met somebody who had provided a DNA sample, don't know how that is. And for that, one would have to go. For doing that, one would have to go to these countries, and it would be easy to find people who have been analyzed, because in some of these studies, the names of the villages are given, and that would make it easy to retrieve the people. But I frankly don't know. But German Roma scholars were very shocked. That's all I can say.
Petra, a question for you. You suggest that public health failed the Roma, who defied recommended measures. The person who was asking that asked, I wonder if the reaction was based on the repeated failure of public health to move beyond a biomedical model of disease. So vaccinated, to speak, to see the doctor, and et cetera, et cetera.
The other cause, instead of recognizing the context of people's lives, risk, how they will choose.
You know, I think these are all really excellent questions, and I think I'm going to kind of skirt answering it by asking a counter question, which is, you know, those of us who have academic backgrounds, right? We have so many of these really, I think, usually very important concerns, you know, about these systemic issues, about you know, exactly where are people living, what are the larger questions we need to be asking when we have a public health approach to something like a pandemic, right? A minority in a pandemic. I feel like we are all looking at the proverbial elephant from our, you know, from at whichever part is closest to us. And so I think if you ask, you know, a Romani mother who's a homemaker, and if you ask a Romani nurse, and if you ask, you know, I don't know, the NGOs that I was blaming, and yes, I am very angry. I am very angry at our own NGOs. I'm sorry. They're going to give you different answers, right? And I think the question I was asking, and I still ask in retrospect about this particular situation, which is COVID, when we're not going to solve the larger issues, we didn't have time. We didn't have months or years or decades or centuries. We had days to save people from dying in the months before that vaccine was developed, and then in the months since when they haven't taken the vaccine. What was the effective thing that we could have done? And I think that's really the question that nobody has asked. None of the NGOs, none of the academics, what are we supposed to be doing right now? What has been effective? So for example, we know that Romani pedagogical assistants have been effective in schools to deal with issues right now of children right now who are having trouble having enough days in school right now, right? They're not going to solve the larger issues. But, and yes, I agree. But actually, no, I mean, to me, the largest issue wasn't overcrowding or any of these things. It was that just like most people, but in many ways, particularly Roma, were not willing to give up their time together, being social, and having their weddings and their parties and their baptisms, and they didn't want to wear masks. And and I'm sorry if people think that's simplistic, but that was the issue right now, and we did not address it.
So I'll take two questions. All right, I'm going to ask the other question that you had at the end. As a Roma attorney and a CRT scholar, I constantly ask myself, where does the law fit? For Veronika, we know there are privacy laws. Yeah.
Well, we know that there are privacy laws in Europe, and we hear that constantly when we're talking about, well, we can't implement certain structural reforms, right, because we can't collect data on race. So where was the law in that scenario when we're collecting the most private data, if you will, right, the genetic data? So what, can you give some context around that? Yeah,
as I said, in the early 1990s, there was just no informed consent procedures in these countries. And there's even one publication of one of the most important geneticists in the field who said, well, in communist countries, informed consent was not an issue because the doctor-patient relationship was just very different. So that is not to say that there were not informed consent procedures later on. They were implemented, but very often they were completely inadequate. And then the big issue also is forensic genetic studies are based on genetic material and data that has been collected in prisons and in law enforcement processes and by the police and yeah, all over. And of course, they don't take informed consent. That would be a ridiculous idea. And that data is being transferred to medical labs. They work with that data and the other way around. There is data that has been collected in clinics that goes to the law enforcement field. So no, it's not, it has never been an issue. And there are wonderful geneticists around who are very shocked about all of that. But there are also geneticists who say, come on, all these privacy protection laws, so awful. How are we supposed to make any progress in science if we watch these laws? But they don't see that this is of any importance. And if you then tell them, yeah, but you would not like your child to be DNA examined and without an informed consent. Yeah, well, yeah, that's right. But all that, it's not taken serious.
One last question, that's for Martin. As somebody who sits in an academic program on Romani studies, where do you see the future of Romani studies?
Thank you for the easy question. Whoever asked it, I would or maybe also invite other colleagues to reflect on that. But for me, I think this conference and this program is a good example. Also, I would like to advertise the Romani Studies program and how are they different from earlier Romani studies. I don't want to go into a detail because in the previous panel, Ioannida and others also mentioned about the Orientalist, folklorist, racist Romani studies, which is still around, I have to tell you. So it's just to give you one illustration, in 1888, so in the 19th century, Gypsy Lore Society was founded, which still exists. They still have their annual conferences. And we heard about the genetic studies. So I would say that, unfortunately, we are a drop in this ocean of, racist science, but my vision is that we will reinforce somehow this approach.
Well, we really hope that this conference, which I've tremendously enjoyed, is more than a drop in the ocean. It's sort of a catalyst for that change. So with that, thank you very much, everybody, including our colleague, Carmen, who joined online. Everybody, thank you so much. Really appreciate it.